The IMpower150 trial looks at a backbone, a control arm, of carbo with paclitaxel and bevacizumab in patients with advanced non-squamous non-small cell lung cancer, and compares that to the same chemo and bevacizumab with atezolizumab, or in a third arm, chemo with carbopaclitaxel and atezolizumab, but without the bevacizumab. Now, one interesting thing about this study was that it was first line in terms of chemotherapy, or at least for a chemo-naive population, but unlike so many other first-line trials, this included patients who had developed acquired resistance to an EGFR or ALK-based therapy if they had one of these driver mutations. That population comprised 14%, so not a huge amount, but a pretty healthy population that intriguingly gave us the first glimpses that immunotherapy really can be effective for this subset of patients with driver mutations. And particularly when you look at the pooled results for EGFR and ALK positive patients, the benefit that was seen in these patients with the addition of atezo to carbo and bevacizumab was as much as, or even slightly higher, but basically very comparable to that in the broader population, where we also saw significant improvement in progression-free survival and now overall survival. But when we looked, divided it further into EGFR mutation positive and ALK positive, the benefit was particularly strong in the patients with an EGFR activating mutation, exon 19 or exon 21, with a hazard ratio for progression-free survival of 0.41. And so this is really quite striking and suggests that it could be very, very feasible and ideal, arguably, to pursue this kind of approach for patients who have developed acquired resistance, who have an EGFR mutation, and have exhausted their EGFR-directed therapies. We don't know whether the benefit seen here is due to inclusion of bevacizumab, due to the atezo, and is perhaps going to be seen and generalizable in many different trials. But for now, this is the first foray into that at least tells us we were very wrong about the preliminary conclusion based on the second-line trials that showed these drugs, at least as monotherapy agents, don't work for EGFR mutation positives. It's not fair to say we should dismiss these and not offer them or relegate them to a very late line of therapy at best, but rather that there is a potentially valuable role, and we just need to figure out how best to utilize immunotherapy in patients with a driver mutation, and especially those with an EGFR mutation.